My name is Dr. Rebecca Omokaru Okolo. I'm the founder of HealthThenMore and the co-founder of Progeny Cerebral Mentorship Program. I started HealthThenMore in 2015. It's an online community for health professionals from all parts of the world so that we can interact. I share quizzes, I share news, and I share medical information there. And over the years, that since 2015 to 2020, it has kind of evolved into the Dr. HealthThenMore tutorials. So a little background about me is I'm a Nigerian, yes, and I've written and passed the licensing exams in the UK, the USA, and Canada. This means that I have written and passed the PLAB 1, the PLAB 2, the MSRA. In the UK, in Canada, I've written and passed the EE, the QE1, the QE2, the OSCE. In the US, I've written and passed the Step 1, Step 2 CK, Step 2 CS, and the Step 3. And I've also been accepted into a postgraduate training program. And so after doing all of this, I felt like it's time for me to share my knowledge and how I was able to achieve all of this with others coming after me. So I'm going to today is an OSCE skills tutorial because I kind of always talk about exams in the terms of it's all about strategy, right? And would you like to ask me something? Make sure your OSCE is about the patient. It's not about you eating all the checklists because as we said, communication is important. So make sure once you start listening to yourself, I'm the one talking. Tell the patient, do you have any question for me? Make sure it's not just you because someone watching from outside is you are making the patient feel like this is an interrogation. It's not a police station, right? It's supposed to be an interview. So in an interview, you ask questions that will make the candidate talk back and give you a lot of information. So try and do it in that way that you hear a lot from the patient and it's not just you going, where is the pain in my left abdomen? How does it feel? It feels like cramping. On a scale of 1 to 10, how is the pain? How would you rate the pain? 9/10. Does the pain go anywhere? It goes to my back. And what time does it start? 9 a.m. So it's not like they're hearing you a lot. But if you say, can you describe the pain for me? The patient says, oh, doctor, I have this pain in my abdomen and it doesn't let me sleep. And you're like, okay, tell me more about this pain. What would you like to know? Is there anything else? The patient has to talk. So your goal in the exam is to get the SP to talk and for you to listen. It's not for you to talk. That's it. Okay, please continue.
Yes, I think you said that it's important for you to listen to your patient. And sometimes when you don't listen, the SP will not tell you the crucial information. So at this point, you want to be honest. You want to make sure that you show empathy, like you have to show them that you really care so that such information, the crucial information in that station, you are able to obtain it from the SP. Sometimes in cases whereby maybe it's gender identity problems, those are personal things that there are some patients that they are not willing to share. But when like the patient sees that you are listening to them, you're showing empathy and you are responding appropriate to their action, they will probably release some important, scroll up, Dr. Becky, some important or crucial information with you. Then also, when you are being asked to do physical examination, there are some examinations that you will not be allowed to do in the exam, such as doing genital, rectal, and vaginal examination. So it is very important for you to mention it to the examiner. If you don't mention it, you are not going to get the score for that. Then also when you're doing a physical examination, you want to verbalize as possible. You want to tell them what you're looking for. You have to take appropriate um you have to take appropriate you have to take appropriate sorry, you just have to like explain what you're saying to your patient and as well to your examiner. Make sure that you do not use medical jargons at this point. They're not providing enough directions in management station. This is talking about when you are in a case of emergency, like the scenario is accident and emergency or trauma. You always have a nurse by you. It is important for you to acknowledge the presence of the nurse that is there, who is ready to help you. Give her some instructions, tell her things to do, and while you are managing the patient, you're also communicating with the nurse as well as your SP. And one thing here is teamwork. They want to see that they are able to work with you at the hospital and you acknowledge your team. Then missing the urgency of a patient's problem. There are some cases whereby it is very important for you to manage what is going on. Like you're in a trauma case, you have to check the airway of the patient, breathing, circulation. You do the ABC. So you make sure that you are addressing what is going on before you go back to find out what really went wrong. So there will still be time for you to probably go back to take history and identify um, the problem so that you can manage it appropriately. Okay. Then also, I think we had spoken about it that talking too much. You don't want to talk too much. This is OSCE exam is not a place whereby you show them that you are here to show off, probably lecture the examiner. You just want to be as professional as possible. You want to explain, carry your SP along, tell them what you're doing. If you want to perform a painful maneuver, you take and you probably tell them ahead that I would be doing this maneuver, it might be painful. And just probably take permission, the appropriate permission before you go into your maneuvers. Then giving generic information, it is very important that when you are being asked to manage, probably for example, non-pharmacological management, you tell the patient, oh, take little salt, exercise. And when you are giving such information, it is important for you to tailor it to why you are telling them to do that specific thing so that it would improve their health in the long term. Don't just say, oh, don't just say that don't just say what is generic because you are a physician, so they expect you that there are some details that you have to have as a physician, and you should relate it in a way that your patients understand and it doesn't sound like a medical jargon. And also when you are giving management, it has to be an informed decision making. So you don't just tell the patient, do this, do this, do this, do that. You have to ensure that you have to carry your patient along and tell them why I'm asking you to do this, and explore if there are things that they can do and you are ready to work with them. Then also in OSCE station, you have quite a number of stations, maybe 10 or 11 stations. Your first station might not be the best, the second station might not be the best, but there's always an opportunity for you to catch up. So stop worrying about what happened in the last station. Just know that focus on the next station and the subsequent station so that you can do better on other stations to get a bit of more marks. Then also trying to impress the examiner instead of treating the SP like a real patient. Always just having at the back of your mind that when you are in an OSCE exam, they are assessing you based on how you perform in a clinic. So you have to treat your SP as a real patient, how you do in real life. You don't have to impress your examiner. They all know that we went through medical school and you've been equipped during medical school of all the skills that is required for you to be a good physician. So at that point, you have to show them that you have these skills and this is how I would relate in real life. be as compassionate as possible. Try to explain what you are doing. Sometimes, like in the QE2 before, SP used to give a score. And they tell us that make sure that the SP you are relating to understands you and they like you so that they can give you a good mark. Because if an SP complains about you, maybe in all your stations you are having over 2 or 3 SPs complaining about you, that is going to affect your entire score. So I think that's all about some of the common mistakes. And one thing about OSCE exam is it, you have to practice and practice and practice. With practice, you are able to work on your skills better, and on the exam day, you are able to probably show them that you are that physician that they want, and you probably do better. Thank you.
Thank you so much, Dr. Bukumi. Thank you so much. So all these mistakes were gotten from the MCC website. We just kind of explained it. But the number 11, I kind of put it in because I'll explain my first QE2. One of the major reasons why I failed was because I finished a station and I got a short answer question in the PET station. That was day 2. And because I didn't do well in that PET station, I kept trying to guess the answer. And I was like, it's this one, it's this one. And then I wasted time. When they told me to move on to my next station, I was still cracking my head. I was like, please let me stay in this station. Please let me stay. When the process of begging, I didn't get to my next station in time. I wasn't able to read the instructions. I was all jittery. That means my professional behavior was gone. I was not informed. I didn't read the instructions well. I didn't know what I was expected to do in the task. Then the next thing was present the case. I was just a complete mess. So let me assure you, when you leave a station, you will never, ever, ever, ever be allowed to go back in that station. So forget it. It's hard for you to see. Don't learn the hard way. You will never be allowed to change one single thing once that bell goes off. So once you finish the station, move on or mess up your next station. 2 options. You leave it behind or take it with you and fail the next one as well. That is it. Thank you. So we'll move on to the next slide. My screen is frozen. I don't know why. Okay. So this is the next thing. It says how to prepare for an OSCE exam. I know this is a very common question. How should you prepare for an OSCE exam? Now, before the OSCE, this is how you should. For every common symptoms, you should be prepared to answer these questions. So let's say, for example, cough. Let's say cough. That's what the patient has. We know cough is a common symptom. So you should know at least 3 differentials, 3 common differentials of cough. You could know 5. Now, the cough of pneumonia, how is it different from the cough of COPD? How is it different from the cough in lung cancer? Like, try to identify the key parts in the history that will tell you the differences between the cough. Do you understand? So, or let's say, for example, chest pain. The patient has chest pain. How you differentiate the chest pain of musculoskeletal pain from the chest pain of pericarditis, from the chest pain of MI. So I will know that if the patient tells me a crushing pain, MI, and the patient says, oh, it's relieved when I lift forward, I'm like, pericarditis. If the patient says, oh, I lifted some weights a week ago, I'm like, musculoskeletal. So what are the key parts of the history that will help you differentiate one cough? So that is how you should study. You take cough, you study it that way. You take fever, you study it that way. You take painful urine or whatever, do it that way. Now, a person has back pain. Back pain could be due to a disc prolapse. It could be due to what else? You know, whatever, muscle spasm. Now, what are the red flags in back pain that will make me know that this is a dangerous back pain? You have to now say, oh, sir, are you able to feel, do you feel numb when you wipe your bum area? Now, if it says yes, you're like, something is going on. So are you still able to, do you still have sensation down there? Like, those are the things that the red flags that you should know for every symptom. A person with cough that is having weight loss, loss of appetite, you're like, and he's smoking, you're like, red flags, red flags, red flags. Could this be cancer? So what are the red flags for all those symptoms you are studying about? Now, if you should find out that, okay, this cough is a pneumonia cough, how will you manage it in terms of what are the examination findings you will get in that patient? That is how you should do that. Then the treatments, the follow-up, just go on that way. How will you safety net the patient? The patient that has pneumonia and all of that, like, what will you tell the patient in terms of safety net? What are the things to watch out for? Things like that. Now, before you enter the station, this is very important. You should pay attention to what is written on the door. Put down the important things such as the patient's name, the vital signs, and possible differentials. Then whatever mnemonic you want to use for your history taking, make sure that you have that down. For me, there was a simple trick I learned for how to divide my notes, and I used it in my second QET. It really, really worked for me. So you can find that out. Then in the station, the notes you took outside, make sure that you also you use it in the station. So it's not about just taking notes. Some people take the notes, then they enter the station and they start to do whatever they wanted. See, in an OSCE exam, I can tell you there is no time to think. It's either you know it or you don't know it. Now, the notes you took outside the door are to help you appear structured. If you fail to use your notes or you don't have your notes in your head already and you're just there, just bumbling through stations, you will be disorganized. There's a mark for organization. Let the examiner know. So always use your notes. Pay attention to the buzzer. Once the buzzer goes off, the warning buzzer, look at your notes. Was I told to take history and examine? So if you were not examining by that time, you should be examining at that warning bell, right? Because you have to make sure you touch all the tasks. It's better to touch 3 tasks than to do just one and do only one very well. So use your time very well. Now, after seeing the patients, you finished your consultation and everything, summarize. Always, always summarize. How do you know the patient is following what you've said? So you always tell the summarize. Ask the patient, can you repeat to me some of what I've said today to make sure you're both on the same page? Ask the patient, do you have questions? All this is just to get the patient talking. Then manage all your cases with essence. Those that did the platoon know what essence means. All management of every patient you'll ever meet will fall under essence. Means it's either you're going to admit the patient or you send the patient home. Either you tell your senior colleague or you're referring to the appropriate unit or you're offering some supportive care like go drink fluids, go rest, go whatever. You're offering leaflets in Canada. Like if you're doing any work here, you're not offering extra information like what are you doing? You always have to offer a leaflet, offer something, offer more information. Then you safety net, you check, give the patient the next appointment. So that's how you manage all cases. Don't just go acute care. If you follow essence, right, you'll see that you're able to go through your health promotion, acute care, chronic care. Then if you were very attentive in your history taking, you will be able to do the psychosocial aspects in your management as well. So I took down some notes. One of the mistakes is listening to patients, and I was like, when you're doing your OSCE, please be careful not to repeat what the patient has told you. Like if the patient, you've asked a question and the patient told you an answer, don't ask that question again. It shows you're not listening. And the patient, the SP will go, I already told you that. It will be so bad. But should you ever be stuck in such a situation, like, oh yes, you mentioned that. Oh, sorry about that. So apologize and move on if it should happen to you. So that's that. So professional behavior and confidence. You need to appear calm and speak with confidence. A knowledgeable but jittery doctor will not impress an examiner. Confidence comes with practice. And you need to know how to phrase your questions to appear empathetic and respectful.
There's a question in the chat box.
All right.
So will there be a warning buzz regarding time once we are inside the room?
Yes.
At what time will that be?
Always, usually 2 minutes to the end. I think QE2, is it 1 minute to the end?
So it depends on the exam. I think for QE2, yeah, about 1 minute.
Mm-hmm. The NACOSP is 2 minutes.
Yes.
Yeah. There will always be a warning bell. So at that warning bell, make sure whatever you were doing, make sure you've checked off all your tasks. Like, is there examination? Is there counseling? If you were not counseling by that time, start counseling immediately. Yes. Any other question?
No, that's all.
Okay. So what are the common post-encounter questions in an OSCE? So you could be told to list your differential diagnosis. You could be told how what you would rule out. Like, so that means if they ask you what is the diagnosis, you will say give me a differential diagnosis. Then what are the investigations you would order? What are the steps in managing the patient? So basically diagnosis, management, investigation management, DIB. Now, this is a common issue template. I'm sure most of us are already familiar with it, right? You do the OCD, RST, UVAAA, PAMOX first. You can take a screenshot. There's nothing there. So for the OCD, it's also more detailed. You go OSCFD, meaning onset. For example, if it's pain, you want to know the setting the pain started. Was it when you were lifting the weights? Did the chest pain start when you were jogging or at rest? It really helps to know the setting. Then the next thing is the cause. How has the pain been when it started now? The duration and so on. So now for everybody going for an OSCE, if you do not know this guide, you're not yet ready to take an OSCE in Canada, honestly. So you should go on Google, look for the Calgary Cambridge guide to the medical interview. It is impressive. Like, that is the only way to pass an OSCE. You have to know everything in the Calgary Cambridge guide and structure your interview to that. So we're going to do the cases now. I think we're done with our presentation. So Dr. Bukumi is going to play the SP for this role. Is there anybody that would like to be the candidate? So it will be a 10-minute session, and this is the question. A 42-year-old male, Adam Jensen, presents to the ER by ambulance. He is intubated, ventilated, and comatose. Paramedics were called to the scene after he had a seizure. His pupils are fixed and dilated. CT scan shows a major intracerebral hemorrhage. His wife is in the waiting area and wants an update on his condition. Who would like to be the candidate?
So, Becky, there's a question in the chat. What about the Edmonton manual approach to OSCE? That's a very good approach.
I don't know about the Edmonton manual. I've never seen it. So, but I will tell you, the Calgary Cambridge Guide was developed both in Canada and the UK. Is what the residents are using. So I don't know if it's the same thing that is in the Edmonton manual. I've never seen that before. But I can tell you, Calgary Cambridge Guide is the way to go.
I used the Edmonton manual. And I think Dr. Eben, I think you used it as well. So the book was written by University of Calgary residents, and some of their professors were involved in publishing the book. It's a very good manual to use because it contains all the list of symptoms and approach to OSCE. When you compare the Calgary Cambridge Guide as well as approach to OSCE, is the same thing. It's just that the way they had written out their symptoms or the arrangement of the book is different, but it's the same information you'll find in Edmonton manual that is still in the Calgary Cambridge Guide.
Okay. Oh, based on what you're saying, the Calgary Cambridge Guide I'm talking about is not even a book. It's just this simple chart here.
Yes.
Yeah.
That has just,
that is just this
things you are supposed to do in OSCE.
It's just this one page. It's not like a whole book, right? It's just saying in every OSCE interview, my screen is shifting. How you should initiate this session, how you should gather the information, the physical examination, the explanation. It's not a whole book. It's just a model of communication. So for people asking, how should you communicate? This is the model of communication. It doesn't contain the phrases you should use, but it's a guide. like this is what you should follow. Yes. It's not a whole book. All right. So who would like to be the SP? Oh, sorry, you're the SP, Dr. Wukumi. Who would like to be the candidate? Okay. Anybody?
Nobody from the chat.
All right. Then, if there is no volunteer, you can read this second case if there's anybody that wants to volunteer for that instead. So, if nobody is volunteering, that brings us to the end of the class. And it just ends with me basically telling you why you should take an OSCE prep course.
There's a question.
Okay.
What's the question? So I think somebody is ready to take the counseling.
Oh, really? Okay.
Yes.
Okay. So who is the person so I can unmute the person?
It's Empress.
Empress. Okay. Thank you, Empress, for volunteering. I think I've asked you to unmute. All right. Do you want to start the video? You don't have to go on video if you don't want to, but you can.
You know, I'm on the video, so it was okay.
I can see her.
I want to understand, what do you want me to do?
All right. So this is the question for the second case, right? At your last
for the first one, we jumped the first one. The 42-year-old man.
Yeah, the 42-year-old male, Adam Jensen, presents to the ER via ambulance. He is intubated, ventilated, and comatose. Paramedics were called to the scene after he had a seizure. His pupils are fixed and dilated. CT scan shows a major intracerebral hemorrhage. His wife is in the waiting area and wants an update on his condition. So that's like someone's wife wants an update on his condition. Look at all that's happened to him.
Oh, okay. So you want me to approach the lady and give her?
Yeah,
okay.
She wants to know, doctor, what are you going to like? What's going on? So Dr. will be your.
I move on to her first, and I move to her. I walk up to her.
Hold on. No, you're not going to discuss it. I'll give you 10 minutes to actually.
Oh, okay. Then I'll tell you what I'm going to do.
I'll be your SP. Then you will talk to me.
Okay, that's fine.
Okay.
That's fine.
And which of the exams are you preparing for?
Actually, I'm preparing for QE1.
Okay.
Yeah, I just ticked OSCE because I intend to do the OSCE too as well.
Okay.
But I'm just preparing for QE1. Well,
okay.
It's
okay. It's just the timing. Okay, Becky.
I'll give it. It's going to be 10 minutes. Let's just 10 minutes.
Okay,
so
that's fine.
The times. The time starts.
You have to give her 2 minutes to prepare her thoughts, right?
2 minutes will be. Everything is included. You know, it's 2 minutes outside, 8 minutes in the station, right?
Yes. So we'll be giving you 2 minutes to prepare your thoughts, and
so I'll give you 2 minutes to prepare. I'll tell you when it's time to start.
Okay.
Okay. Becky, so you can start timing now.
Start.
Okay.
Okay.
Hello, madam. I am
Hello, doctor.
Okay, I'm Dr. So. I am here. I want to give you an update on your husband, Mr. Adam.
Okay.
Correct?
Doctor, please, can you just tell me what's going on with my husband? I'm so agitated. I'm scared. I'm worried. I don't know what's going on, please.
Okay. I know how you feel, madam. And currently, your husband is being stabilized. We had to take over his respiration because of the seizure that occurred at home, and we've had him. He's being ventilated, and we are giving him oxygen to support his breathing. And
Oh my God. Is he going to be fine? What do you mean by ventilated, all these things? Please, can I see him? I really want to see him. Can
okay,
I see him?
okay, correct. Currently, madam, you will see him, but not at this moment because now we
Oh
have
my
he's
God.
not speaking. We have to take over his breathing for him. He's on oxygen. He has tubes, so he cannot speak to you at this moment.
Okay, but can I just see him? And is he going to talk at some point? Why
Uh,
is he not speaking? What is going on? We were
okay,
just together talking, and the seizures just suddenly started. What could have? Oh my goodness, doctor,
okay,
I'm worried.
okay, madam. We are currently running some investigations on him, and we had a CT scan that showed he had a bleed in his brain. So now we're trying to.
Oh God, God.
Okay, actually, he bled in his brain. We have the seizures are stopped for now, and he's in a sleeping state. And for now, so we're rehydrating him and giving him everything to make the brain rested. Then at some point, we expect him to get better. We had investigations done that already showed that he bled in his brain, and for now, I think he just needs to be rested. And I assure you, you need to calm down and you'll be fine, and you'll get to see him at some point.
Okay, thank you very much, doctor.
Then you're welcome, madam.
You still have 7 minutes to go.
And this
Yeah,
is
maybe
late
she finished quick.
medication.
Okay. All right.
I
Feedback.
don't know. It's been a long time. I've not practiced like almost 4 years.
No. I mean,
It's okay.
yeah, I think you did well. I mean, I think you did pretty well.
Thank
I
you.
mean, maybe I'm going first anyway, so I'm sure my guys that are here will be able to drill more hole. Like, to be honest, I mean, I like your tone of voice. See, whenever you have OSCE like this, there is always a tone. I think we should kind of see ourselves as actors, honestly, because yes, we are doctors, but we're actors. You can come out of your house having had issue with your wife, having had issue with your husband, having had maybe a motor vehicle accident, you get something serious. But suddenly you're seeing a patient who just had a baby. What are you supposed to do? Your tone is supposed to go up, reactive to what is happening. You understand what I mean? And this is workplace. This is what is sort of expected. If your tone is somehow, patients will feel like this doctor is hostile. So that's how OSCE is, because you're changing from different room to room. This room is full of excitement. That room is full of sadness. So your tone has to be reactive to what is going on. And that's your mental state examination for patients. If your tone is not reactive, that means even you are having a psychological problem. So your tone was very reactive. Do you
Thank
understand? It
you.
was like in the tone of what was happening, like something bad was happening. like you were trying to, like, control the situation, trying to make her understand, trying to make her feel like, you guys are putting everything under control. You're, as much as possible, trying to make sure that the husband is okay, and you're trying to make her feel calm. I mean, did you do very, very well? Not really, in the sense that, in the sense that some of the remarks that you made, could be better, and I will leave them to do that. I'm very sure that they already have all those holes that they're going to tell you. Do you understand? So the issue will now be the remarks, talking, saying some things that you're not supposed to say, also understanding the situation better, and not putting yourself in a hole.
Lying.
For this that happened, I will leave them to punch a hole in everything you did. But I think that your tone was good, and you're, as a lady, I mean, ladies pretty do very well in OSCEs, because I don't know, you guys are just naturally kind of, you know what I mean? Sometimes when you're making mistakes, the fact that your tone, your body language, we didn't see your face, but I believe that your body language.
No, I didn't close my face. I'm here.
Yeah. Yeah. So if you had seen your body language, I believe that would have been good, because your body language is so important in this kind of situation. The way you talk. I was in with one of my nurses at a home, and we had this, patient, very old patient, 92-year-old, who, was basically close to end of life. And I mean, some of these patients, when they're close to end of life, sometimes they come in and they come a bit out, and it seems like they're getting lucid. But reality is that they are, slowly creeping towards that period. Now, the relatives, some relatives kind of feel like, maybe my nurses are not doing enough in the home, maybe this, maybe that. We might want to see the doctor, talk to the doctor, what's happening, you know what I mean? And yeah, so this day I was there. I had gone to see the patient, and I was just rounding off with my with my nurse to say, okay, this is the plan, this is the plan, this is that. And I heard that one of the relatives wanted to talk to me. It was something like this. This is real life, and I'm telling you, something like this. And I was like, oh my God, what am I going to say now? I only just took over the care of this patient not too long ago. And then, I just went into the room, just like you talk, calm down to their level. Of course, you don't understand how they feel. You can only, imagine. So you just try as much as possible to put everything in perspective and not nail yourself. I was being asked, is it possible that he might be able to be in this position for like 24 hours to 3 days, because we want someone to be able to come and pray for him. That's his last wish. What would be your response to this? So you just has to be in that situation. You just have to like be in that acting position to make sure that what you're saying, if you're being told as a person, you're going to feel very happy about it. So, I quickly took the guilt out of the relatives, and I told them, I was like, immediately I was already sensing guilt. So I'm like, during this period is so tough, and if I were in your shoes, it might be, I might be having a sense of guilt. But having a sense of guilt is one of the hardest things when it comes to grieving. You're already in a position of grief right now, and which means that it's a very tough position. You get. So feeling guilty, is one thing that you do not even want to do. And why? Because you don't even determine you don't determine the end of life of the patient. Do you understand what I mean? Like, you don't determine the end of life of the patient. End of life tends to come. Sometimes you don't predict it. It can just come. Some of these situations just come, and no one is able to predict. Even with our best plans to have things done just before the person dies, things like this happen. And I'm sure that even the patient who is, in this position would probably understand if they were here, seeing that you have actually tried your best. So you see, I'm trying to diffuse the situation. I'm trying to take off the stress of that person, take off that burden, making that patient feel less guilty or not guilty about what is happening, because it could, further worsen their situation. And already they are trying to transfer aggression on us. That maybe we didn't take care of the patient enough. That's why the patient couldn't wait for them to be able to do what they were thinking to do for the patient before the patient passes. Do you understand? So, I mean, this is just like, what I just wanted to, leave you with. I'm sure they'll punch a lot of hole into it, just let you see and that. But, just putting things in perspective and knowing that it's your behavior, it's acting. And when we were done, I mean, it's not pride or anything, but, the nurse that was with me she was very, very happy. She was like, thank you, doctor. She still sent me a text. She was like, awesome job yesterday. Do you get? And it's not because I mean, it's not because I did any special diagnosis. I didn't, you understand? I didn't say, let's start doing blood sugar. I was just like, okay, what is our goal of care for this patient? Do you get? If goal of care is allow natural death,